So congenital ptosis with all the variations, including all the causes of complicated ptosis, can be a challenge both in diagnostics and in management. Similarly, acquired ptosis has a very wide variety of etiological causes, and you need to look at all of them, and in your diagnosis try and find out the specific cause before you carry out your management. So as anywhere else, the important components are history taking and examination. The history must concentrate on the age of onset, and this can often be confirmed by previous photographs. Any predisposing factors to the condition like trauma or previous ocular or eyelid surgery, which sometimes bring about a ptosis, or any orbital surgery, these must carefully be asked for. Any variability, as Debraj was pointing out, should be carefully looked at. Any family history may be important in congenital ptosis. Not always, but very often you may get a history specifically in blepharophimosis syndrome where there is an autosomal dominant transmission. Treatment of any previous therapies, surgery must carefully be taken. The evaluation must include the general physical examination, as we have just been talking about the systemic associations. A neurological examination becomes particularly important in the acquired ptosis, where you want to exclude the neurological causes and look for them and look for any associations, and a good ophthalmic examination is always important. In ptosis, visual acuity is important both in congenital and in acquired ptosis. In congenital, because there is often an associated refractive error, amblyopia, which need to be carefully assessed and managed. Examination of the pupil is a useful clue to the diagnosis, particularly in conditions like Horner syndrome, third nerve palsy, and other neurological causes. In the evaluation of ptosis, determination of the severity of ptosis is particularly important, and therefore measurement of palpebral aperture is vital. You need not just the vertical but the horizontal dimension as well, because that needs to be corrected in conditions like blepharophimosis syndrome. Looking down can be useful in differentiating a congenital from an acquired, where you find the congenital levator relaxing less well, causing the palpebral aperture in the down gaze to be larger, whereas that would not be true in an acquired ptosis. So as we said, amount of ptosis is important. So vertical size of palpebral aperture is a help, but MRD1 is more specific, where you measure the distance from the pupillary reflex of the light to the center of the eyelid margin in the primary gaze, and this removes the fallacy caused by malpositioning of the lower lid. So this MRD1 normal is usually around 3.5 to 4 if we expect about 1.5 millimeter to 2 millimeter coverage of the pupil. The grading of the ptosis is accordingly carried out. A 2 millimeter or less ptosis constitutes a mild ptosis, whereas anything less than 4 and more than 2 would come in the moderate group, and a severe ptosis would be one that is either 4 millimeters or more. Ocular motility assessment is important not just in congenital ptosis, where you may have a superior rectus underaction or a double elevator palsy because of the development of levator muscle from the same myotome as these muscles, but also in all the neurological cases may help you pick up cases of ocular myasthenia as well. One of the most vital tests is levator function, where after a proper blockage of the frontalis action, you make the patient look up from the extreme down gaze position. In children, it is also important to ensure that the patient's head rests against a wall so that he cannot move his head. The other test which may be valuable in infants is everting the lid and looking to see whether that gets reversed on its own or not, the so-called eyelifts test. The levator action is then graded as poor if it is 4 millimeters or less, fair if it is 5 to 7, and good if it is 8 millimeters or more. There are some who would grade more than 10 as excellent because that would help them choose the Fasinella Servet surgery in proper cases. It is also important to assess the margin crease distance, which is the distance in the downward gaze between the eyelid margin and the lid crease, the principal lid crease or the most prominent lid crease. This can be altered very significantly in aponeurotic ptosis and may be helpful in diagnosis. But one important element is the lid crease height in the primary position, the so-called tarsal show, which is what you need to match in your surgery. So that is why the measurement of tarsal show is important, because it has a very important impact on the aesthetic appearance, at times even more than the presence of ptosis. And one factor that you must keep in mind is the Herring's law, because you would notice that Herring's law often operates in cases of acquired ptosis, at times in congenital ptosis as well. As you see here, when both the lids are drooping, this eye has a fairly good lid position, but when you lift up this eyelid, the other lid droops down because of the Herring's law. For the security of the patient's surface after the surgery, it is important to look for Bell's phenomenon, because lack of thalamus is an integral part of your surgical procedures, and so is the corneal sensation. You must ensure that there is no dry eye, corneal sensation is good, and the Bell's is working well before you undertake the surgical procedure. A phenylephrine test is useful in differentiating those cases which would respond to Müller's muscle resection procedure, and now this procedure is one of the procedures of choice in acquired ptosis, aponeurotic ptosis, and therefore this test is vitally significant. Must look for all the associations that we spoke about: superior rectus or a double elevator palsy, presence of jaw winking, or the presence of blepharophimosis syndrome, which must be thoroughly evaluated before planning the surgery. Looking for causes of mechanical or secondary ptosis such as papillae, which may occur due to allergies or because of contact lens use, must be looked for. Presence of a lid mass causing ptosis should be looked at. I think this aspect has been covered well by Debraj, so I'll skip it. And you can see how dramatic the eyes test can be in a patient with myasthenia. Therefore, it is an important test, and so are the drug tests such as neostigmine test, because they can show extremely dramatic results. The decision making is based on the diagnosis that you make and the evaluation that you do, and the decision making involves age of surgery and the choice of surgical procedure. We would do most cases for congenital ptosis at the age of 3 years or more. There is an increasing literature suggesting that an earlier levator surgery is more effective. 4 years or more for fascia lata sling surgery, except in cases where pupil is covered or amblyogenic factors are considered to be significant, such as causation of a refractive error or astigmatism. The choice of surgical procedure is dictated by the parameters that we spoke about, but also on whether there are any associations, whether it is bilateral, and the amount of ptosis, levator and levator action remain the main factors in decision making. And these are the procedures that are my personal choice, but there are variations. In acquired ptosis, the choice of procedure would be based on management of the cause, and very often that is all that is required. But in others, you do need to manage the ptosis, and particularly the most common entity, the aponeurotic ptosis, needs to be evaluated well to choose whether an external procedure like levator reattachment or advancement is needed, or whether a Muller's procedure would do. And associated concomitant handling of things also may need to be carried out.